My name's Fred Cerise. I am an associate professor with LSU School of Medicine. Immediately prior to that, I was the vice president for health affairs and medical education with LSU, where I had responsibility for the 10 public hospital system in Louisiana and the 2 health science centers. There are a lot of changes going on in the LSU system right now. I think fundamentally, you're seeing a philosophical shift from a public delivery system to the state attempting to purchase that care and from other providers. And the concerns that I have about this shift are not that it can't be done, but that we haven't done as a state an appropriate analysis to understand, one, what are the goals that we're trying to achieve? Are we trying to get better quality? Are we trying to get lower cost? Are we trying to get greater access? That's not been really clearly defined. Are we trying to get a better environment for medical education? Those things haven't been clearly defined, and therefore not studied appropriately to see, how are we going to achieve those goals. So if the goal is better access for medical education, then you would expect that your medical education experts would plot a strategy, much like you would do a major curriculum change in a medical school. You'd pull all of your leaders together, the people that know the information. You would do a process. You would involve students. You would involve faculty. But that process hasn't taken place. If the goal is to lower cost, there is a lot of data. There are a lot of data out there in the literature that indicate a delivery system that a public safety net or a safety net delivery system can deliver care to a population at a fraction of the cost it would cost to insure the entire population. Health Affairs just came out with something in the past few months that looked at model safety net systems across the country, and they came to that conclusion, like others have as well. In fact, in Louisiana, after Hurricane Katrina, there was a study done that showed that the cost to insure the uninsured in the state would be $2.3 billion, which was several times the amount that's paid in the safety net system today. So if the charge is to lower cost, then the state hasn't done the analysis to show how that same level of care, same access to care, can be done at a significantly lower cost. And so if the objective is to improve quality, same thing. We haven't seen an assessment that says we're looking at these quality indicators within the LSU delivery system today, and LSU's performance on these quality indicators, and we're going to move to these systems that have these metrics on their quality indicators. That type of analysis has not been done. People are free to talk. I mean, people will tend to talk about quality of healthcare in Louisiana, and will say things like Louisiana has the highest cost and the lowest quality of healthcare. That's true in the Medicare program. We're at the very high end of cost per recipient, and we're at the low end of quality per recipient in the Medicare program of the state. Well, that care is generally not delivered in the public safety net system. That's delivered in the private delivery system in the state, which is the system that the administration is currently proposing moving the care into. And so if your goal is to improve quality to lower cost, it's not a logical step to move from a lower cost, high quality system into that system. There may be individual examples where that makes sense, individual instances where that makes sense, but we're not seeing that type of analysis to go into this planning. Instead, we're seeing kind of global generalizations that say we've got to modernize, we've got to be cheaper, we've got to do things like this, but we're not seeing the detailed analysis to back up those broad generalizations.